or imaging structures which are moving very fast, like the coronary arteries. So all in all, to sum up, the NAEOTOM alpha offers photon counting detector technology with the ability to reduce radiation dose, intrinsic spectral sensitivity, higher spatial resolution, and all of that being a dual source CT scanner. For cardiovascular imaging and the improvements it provides there are three main areas I want to present you. One of them is the ability of virtual non-contrast imaging or the coronary calcium scoring in post-contrast images. The other one will be about the virtual monoenergetic reconstruction it provides. And lastly, and I think this is the most important improvement, the ability of ultra-high spatial resolution CT angiography or quantum HD CT. Quick reminder for those who don't work or use it every day, like the Egerton score is a quantification of the coronary artery calcium plaque burden and a good risk stratification for future major adverse cardiovascular events, and also in current guidelines to guide therapy with statins. And regularly this is performed where you have an anteposterior scout view followed by a contrast, by true non-contrast CT, and then contrast CT to image the coronary arteries. And here we see one patient of our clinic who had a true non-contrast CT, and you see a lot of calcium here in the left anterior descending artery with a calcium score over 800. And this is the contrast-enhanced CT on the photon counting detector. And now look what happens with the ability of intrinsic spectral sensitivity. You get rid of the iodine and see only the calcium. And because it's so beautiful, I want to show it to you again. Here you have the iodine, here it's gone. And then you can measure the calcium, and you see there's a slight discrepancy, but the overall percentile of the risk in this patient, it was similar. And a recent study published by a research group from Zurich, they showed the reliability of this method in TAVR patients derived from the late enhancement CT scan they performed there. And when you think about it, this has future or major possibilities for the future where you could employ a calcium scoring in post-contrast thoracic images where you stage your patient and then you can assess its risk factor not only in true non-contrast cardiac CT, and also maybe in the future this can be performed automatically or with AI. So one major advancement of this technology. The other one with intrinsic spectral sensitivity, one thing that I find very important, very helpful in the clinical basis is like the virtual monoenergetic reconstruction. And here I brought you one patient who has a common iliac aneurysm of the left iliac artery, and this was scanned on an energy integrating dual source CT scanner. And in the follow-up, you see 6 months later, there's no dynamic changes in this aneurysm. But this scan was performed, the follow-up scan, with the NAEOTOM alpha using only 30 milliliters of the contrast agent, whereas in the previous scan we had 80 milliliters. So this can be particularly important for patients at high risk for contrast-associated kidney disease or nephropathy. And how we do this, or this triggered like a study which we are currently preparing to submit. And this is, you can apply or acquire the spectral images and then quantify the iodine, but also reconstruct monoenergetically close to the iodine KH where you selectively increase the intravessel attenuation. And as a quick reminder, iodine has its KH at 33 keV, where you have a peak attenuation of iodine, which is like in your contrast material. And when we have the spectral imaging and we reconstruct at 60, 50, 40 keV, we increase selectively the attenuation in our vessels. That's the whole strategy. And now the big game changer in computed tomography, and especially in cardiovascular computed tomography, ultra-high resolution imaging. This, I will talk a little bit about a study we published 6 weeks ago in radiology, where we assessed the accuracy of this novel technology in a high-risk cohort. And with CT or conventional CT imaging, there's this dogma or known limitation where you overestimate stenosis when you have high calcified plaque burden, as here seen on this image, where you would suspect severe stenosis, but then on the angiogram you see only mild wall irregularities. And so this is a hypothesis-driven study, and it triggered the hypothesis that we can overcome this limitation using the novel photon counting detector technology. And the hypothesis would be obviously that in this high-risk population, which are indicated for transcatheter aortic valve replacement, where you cannot apply any beta blockers, where you have high calcified plaque burden or previous coronary intervention, and basically impossible to successfully scan for cardiac CT, that there provides high image quality and diagnostic accuracy for the presence of coronary artery disease. And all patients were consecutively enrolled and received an ECG synchronized photon counting CT scan employing the Quantum HD cardiac protocol, and we compared the results of the CT reading independently with the results of the invasive angiogram, which is always performed in this patient population. In the final cohort, 68 patients were included, so a small study, but nevertheless with meaningful results. And when you look at the patient population, the mean age was 81, and it was balanced among genders, and 22% had prior stent implantation, whereas 35% presented a coronary Agatston score, a calcium score, over 1,000. And this is an underestimation because obviously you don't count segments that have been stented. I want to show you two examples of this study population. One of them is of a 67-year-old male patient who came or was referred to us for valve-in-valve replacement. On the angiogram you see his previous valve, and this is a CT acquired on a second-generation dual-source CT 6 years ago to plan his first valve replacement. And now look at the improved image quality of the right coronary artery and the left coronary artery on the ultra-high-resolution scan. In these images, you can easily assess the coronary arteries, and these patients don't require always pre-procedural diagnostic in coronary angiography. Another example which I find very fascinating, and it's one of my favorites of this cohort, is of an 85-year-old male patient who had an Agatston score over 4,000, so very high calcified plaque burden, and presented a previous stent implantation in the right coronary artery. Normally, you would never do CT imaging non-invasively in such patients, but also here, you can see where you have a lot of calcified plaque, almost no blooming artifacts, so you can assess the vessels, and also within the stent, you can exclude instant stenosis, which is confirmed on the angiogram with high diagnostic confidence. Overall, the diagnostic accuracy of the whole study population was 88%, and there was a good diagnostic performance on the participant, vessel, and segment-based level indicated by over 0.9 values of the area under the receiver operating characteristic curve. When we look at subgroup analysis for patients who had an Agatston score of 1,000 or higher, then we have a very reasonable 83% accuracy, or with patients of prior stent implantation, 93%. And this is, for example, another example of a stent where you can easily assess the instant lumen and confirm no restenosis. But this works also for smaller stents or much smaller stents. And with the ability of reconstructing images at a sharp vascular kernel, you can also assess the small stent struts and distinguish calcified plaque from the stents. So when we look at current guidelines for the management of coronary artery disease, which were published 1 or 2 weeks before, then they still recommend that coronary CTA is only reasonable as an alternative to exclude or to assess stent patency, and only with stents who have a diameter of 3 millimeters or larger. And everyone who's employing photon counting detector technology knows that this will be the novel gold standard for evaluating stent patency, likely increasing the guideline recommendations. But we have to provide the evidence for that and create more widespread of the technology. Last 3 to 4 minutes of my talk, I want to focus a little bit on the improving of neuroimaging, but keep in mind I'm a cardiovascular radiologist, so this is the optimized contrast to noise ratio that it provides, where you can decrease the radiation dose, and especially in pediatric imaging, this could be beneficial. Here of a 7-year-old patient where we excluded brain hemorrhage. He had a pacemaker and anticoagulation, and unfortunately fell 2.5 meters with very reasonable radiation dose and good image quality. Or another where we have a very obese patient with normal pressure hydrocephalus, and we had to control his ventriculoperitoneal shunt, and we do it with very low radiation dose. The other, as we talked before, the intrinsic spectral sensitivity, allowing us to perform monoenergetic images, virtual non-contrast images, iodine maps, pure calcium, pure lumen, or material decomposition. And here one potential benefit, I think, is of the distinction of the gray and white matter interface using or reconstructing images at low KeV. And this is for the same patient where we have the image at 160 keV, where it's difficult to distinguish the gray and white matter, and here at 40 keV you can beautifully see the basal ganglia. And for example, this could benefit in the non-invasive early detection of stroke, I assume. One patient of our clinic where the untrained eye could suspect here in the left frontal lobe defect after ischemic stroke, and then you can see in the mono KV images, no, you have a lot of gray matter still here, and then on the MRI image, it was cerebral lymphoma. One potential case where it helped. The other one is you can accentuate or confirm that you have a contrast-enhancing lesion. Here you see in the post-contrast a CT of the brain. I cannot see it really here, like a bright hyperdensity of the cystic lesion, and then you deconstruct the images using its spectral sensitivity, where you don't see in the virtual non-contrast images any hyperdense lesion, but on the iodine map, and this was, for example, a cerebral metastasis of lung cancer. And this is a fact that we observe in many body parts. Here I'm showing you from our department CT imaging of the breast, and when we use the iodine map, you can beautifully see that this patient has invasive ductal carcinoma. Works also for the abdomen and many other regions. And the other one, and this is known for dual energy CT, you have the ability to decrease artifacts here, metal artifacts after coiling of an aneurysm, which is completely resolved after reconstructing at high KeV, and this works also for other metal implants. And lastly, you have an improved contrast-noise ratio when you apply images at low KeV, here with 50 keV, where you can beautifully assess the carotid artery, and here you see the occlusion in the right cerebral median artery and the M1 segment. And of course, perfusion CT is also possible with this scanner. Lastly, and also here, like in cardiac CT, I think the vast or the major improvement that we observe is that of quantum HD ultra-high resolution imaging, one for the assessment of the carotid arteries, where you can quantify the stenosis, but also have a good characterization of the plaque, where you see calcified and non-calcified parts of the lesion, or also visualization of very small vessels within the brain. And we have seen this slide before. The visualization of small structures is vastly improved by photon counting detector technology, here visualizing the stapes. And this is the last case I want to share with you from our clinic, a patient suffering from otosclerosis, which can be appreciated first on an energy integrating detector CT, and you have the improved image quality on the photon counting detector CT, all of that while reducing the radiation dose. And just look at the beautiful pneumatization of the mastoid cells, where you can really visualize the anatomy in detail. So to conclude, this is a novel CT technology which provides safer diagnosis because you reduce radiation dose, contains spectral sensitivity intrinsically in every scan, where you can deconstruct the images applying the iodine map or virtually monoenergetic reconstruction, potentially reduce the contrast dose, all of that optimizing a patient-specific diagnostic approach. And the vast game changer, I think, is the anatomy or the visualization of anatomy with great detail, the ultra-high resolution capacity. And all of that lets us conclude that the widespread of this technology, we can already observe it, but it's absolutely expected. At the end, I want to acknowledge everyone in my department who was very supportive the last 2 years, especially my chair, Fabian Bamberg, who sends his greetings, and of course, all our patients. And thank you very much.
Okay, thank you very much for very good